Okay, can we see now? Can we see?
Yes.
So who is going to read for me? So I'm going to be a little snappy. Okay, so a client is receiving an opioid patient-controlled analgesia pump to control post-operative pain. However, when the nurse assesses the patient, or when the nurse assesses the client, she finds the client is pale and hypotensive. The client is pale and hypotensive and has a respiratory rate of 6 breaths per minute. The patient control analgesia pump record shows that the limit for maximum dosage was set far too high, resulting in an overdose. The client is very somnolent and barely responsive. What intervention does the nurse anticipate? So you have a patient that is unresponsive. This is overdose. If you understand the question very well, I don't know who wants to analyze what this question means, who will give us the analysis, but to analyze this question, straightforward, it means the patient has a prescribed dose and patients started using it after the operation. Control analgesia pump is a type of pump they give the patient to be able to control the dosage that the patient gets and maintain them on a free, a therapeutic range of treatment for the pain, so that you don't have to take morphine and wait for 4 hours, and then 4 hours you forget, and then you bring the medication 6 hours later. So in between the next 2 hours, the patient was in pain without medication. The therapeutic level of the medication would have dropped at that, between that 2 hours, the patient did not get it. So the patient control analgesia pump is there to control the frequency at which the patient get the pain medication, and to also control the dosage and the maintain the therapeutic level of the medication in the patient to help control pain on a stable balance, not to have the patient not to have spikes of pain before the pain medication starts setting in. So this patient getting the medication after post-operative. It's for post-operative pain treatment. And now the nurse went to assess the patient, and you have seen that the patient is now hypotensive. You walk into the room, you know this was what the patient came back from surgery and is supposed to be on. Today you walk into the room, you see the patient is pale. That's your visual assessment, what you can see from your end. Patient, you check the blood pressure, you notice patient is hypotensive, respiration is 6 breaths per minute. You know the normal respiration shouldn't be at least less than 12. So now it's 6 breaths per minute. Then you see that the patient, you want to assess the patient analgesia control pump. I told you not to read meanings into the question. So you want to check the pump record, because you know that's what the patient gets for pain. And you see that it shows that the dosage that the pump was set at was too high. So that tells you it's overdose, right? Do we understand? There was an overdose of analgesic. Usually it's opioid. Yeah. This is an opioid overdose. So you would give an antidote to try to revive this patient. But remember the breath rate, the patient is hypotensive and other things. But this is a select all that applies. So in that case, what will you choose to do for this patient? What intervention does the nurse anticipate? So you are the nurse. What do you think will be done for this patient at this moment? Having the patient, you say? So this one, with this question, you should have known how to manage a patient, or you should know the signs and symptoms of opioid overdose and the management of overdose, opioid overdose, what to do for a patient if patient overdoses. Or you should also know more about the patient control analgesia pump. But if you don't know the control analgesia pump, the other hint to tell you is opioid overdose, what you should do for the patient. All those are hints to give you an idea how to tackle a question like this. So what will you do?
First and foremost, stop the infusion.
Okay.
Or discontinue the pump.
You discontinue the pump?
Yes.
Okay. Does that mean the patient will not need it?
I'll give oxygen.
So
and then
you discontinue this one.
Yes. Give oxygen.
So listen, stopping the pump and discontinuing it, what's the difference?
I'll discontinue the medication, just that.
Are you the doctor?
At least to stop further dispensation of the medicine.
Remember, discontinuing medication or discontinuing the pump means you need an order to discontinue. That's not your nursing action. Okay. The safest for you to do is to stop the patient from getting it right now. That's immediately stop the infusion. You are done. You don't discontinue, okay? You are a nurse. So anything that says to discontinue and it has to do with a medication, don't pick it up. You don't discontinue medication. The doctors put the orders in, you only carry it out. So you go and stop it from going inside the patient. So number 2 is out, okay, madam?
Yeah, I know. I mistake.
Yeah.
I'll give oxygen too.
You give the patient oxygen. Yeah. Okay.
So, Sister Pat, the difference between immediately stop the infusion and discontinue the PCA pump.
PCA pump. Sister Pat, what is the meaning of PCA? It's in the question. Read the first sentence. Oh.
Yeah. Patient control. Yeah.
Analgesia. Okay. Maybe if you mention it, you will get it right. It's patient-controlled analgesia pump. It's an infusion. They put the analgesic in the infusion and they hang it and they titrate it. They set it at a certain limit.
Isn't it the same as the infusion? You immediately stop the infusion.
You were asking of 2 things. You said immediately stop the infusion and discontinue the pump. What was the next thing that you said? I didn't get the last part. What was your question?
You were saying we are the nurses, so we don't have to with the medication, we don't have the right to discontinue it.
Yes. So what do you understand about these 2 options? If you see discontinuing the pump and stopping the pump, these are 2 different things. The pump is a medication. The pump, remember, the whole pump is a medication the patient is getting. Now the question says, what will you anticipate will be done for the patient? So you are anticipating what you do for the patient right now. Remember, the patient is pale, hypotensive, respirations are down. Then the patient is barely unresponsive or barely responsive. The patient is more like knocked out. It's not even responding so well. You understand? So what you want to anticipate now is interventions, immediate interventions, what you will do right now for this patient. So if you stop the pump, why do you come back to discontinue it? So what I said is that nurses don't discontinue medication. The pump is a medication. It has an order in the computer. You carry it out. So the safest action for you, the nurse, to do right now is to stop the patient from getting the medication right now. When it comes to discontinuing the pump, it has to be an order that has to be DC'd in the computer. The doctor will say, okay, let's discontinue the pump, the medication. Let's discontinue the patient control analgesia pump. Then you will now go and take it out from the patient. But you are not the one that ordered the discontinuation. You are only carrying out the order. So the best thing, that's how I want you guys to think. The NCLEX want you to be a safe nurse. So the first thing you want to do is to stop whatever is causing this thing right now. So you have realized that the pump was set too high, and this is what the patient was getting. The first and safest you can do is to immediately stop it from going into the patient to cause further damage. So do you understand? Does anybody have a question? I know you guys mentioned to administer oxygen, right?
Yes.
Patients, why do you think the patient will need oxygen? Okay, she's not talking. Okay, so apart from administer oxygen, what else will you do?
Okay, an incident report.
You make an incident report. I think this one is, it should be filed, not tiled.
Yes, no, it's fine.
Yeah, so you will make an incident report. Is that all you will do? You will not give an antidote for the analgesic?
If it's ordered,
Yeah, they say per standing order.
okay, in that case, that's part of it.
So far as it's naloxone, and you know that is the antidote for opioids. So for this question, you want to think it that way. It is opioid overdose, because they specifically mentioned the set rate was too high. So the patient has overdosed it. Barely responsive means you want the patient to respond. So the patient is not responding. The patient is not breathing well. You want to kickstart them. You want to kickstart the heart to start pumping and then to start breathing well. So naloxone. Immediately after stopping the pump, the next thing you want to do is put the oxygen there and give them the shot. You have another nurse preparing the shot, and then you are hanging the oxygen. When they bring it, give them the naloxone. That's what will wake them up. So incident report will come last. So if you were supposed to arrange these things, this is the first and safest you will do, followed by the oxygen, and you have another nurse grab the medication for you, or another nurse grab the medication to come and give it, because the one that take the medication is the one that give it. So those are the three things you will do, but you will not discontinue the pump. The patient has overdosed, it doesn't mean the patient don't need it for pain anymore. That's why you don't discontinue the medication. And besides, nurses don't discontinue medications. I repeat, doctors will do the discontinuation of medication. Is that clear?
Yes.
Can I move on? Do we understand, or we have a question from this? Do we have a question? Patience, can you read this one for me? Pat.
A client is hospitalized in a long-term care facility because of Alzheimer's. Alzheimer's disease. The client is incontinent of urine and feces. The nurse has delegated incontinent care to unlicensed assistive personnel. How frequently should the nurse advise the UAP check the client for dryness?
Okay. How do you understand this question?
I want to take one more.
How do you understand this question? When When you start reading the question, I want you to put it like in your daily living terms, your daily activities. So wherever you work, use that place as NCLEX hospital. So the client has been admitted in a long-term care facility because they have Alzheimer's disease. The client is incontinent of feces and urine. So that means definitely this client will be wearing a diaper. Who agrees with me? So if it's a nursing home you work, or if you have worked in a nursing home and you have the patient is incontinent of feces and bowel, and the patient is moving around, then you have them wear something protective. You teach them to be doing the Kegel exercise for bladder control, but sometimes it's just a medical problem that's going on that they cannot control it. So if there is urine and feces incontinence, you are the nurse. You are the nurse, and you tell the patient care tech to, they are, anyway, before I move on, do we understand what unlicensed assistive personnel is? Because you will see that on the NCLEX when they come to delegation and prioritization. And this is a delegation question. Do we understand what UAP means? Who doesn't understand?
No.
They said unlicensed assistive personnel. That's the nursing assistants. That's the nursing assistants. They don't have license. Understand?
Okay.
So when you delegate, I think I had made a video on the delegation. When you're delegating assignment to these people, you are delegating activities of daily living. How to check patient temperature, how to do patient weight, helping feed patient, help to walk the patient to the bathroom, help to make a bed for a patient. You can delegate those activities. And when you delegate, LPNs can delegate those people. You can delegate the nursing assistants. They work under, they are like, after LPN, they come next. So they are on the floor and they are those, you delegate simple tasks to them. You don't delegate patient care like giving medication. You can tell them to help feed a patient, that's fine. They can feed, they can help assist the patient with eating food. Those who have swallowing problems, they can do it. They can assist the patient, cleaning them in bed, changing them, giving them a shower. So they said the nurse has delegated incontinent care to unlicensed assistive personnel. Take notice of that word if you don't know it, because you see it on the NCLEX. When you are delegating, there are people you can delegate to. How frequent should the nurse advise the unlicensed assistive personnel to check the client for dryness? So with this question, if you don't know about incontinent care or patients that are bedridden, how will you solve it? What is the answer anyway? Who knows the answer?
One.
Huh? Who knows the answer?
I'll choose number one.
So why? What was your reason for choosing number one? Was that the best answer to choose, or you just wanted to choose that?
I know that you have to check on them every 2 hours.
Yeah, so checking on every 2 hours, you assume there would have been some amount of urine production. So you want to check them to see if they are dry. That's it. Very straightforward, okay? Can we hear that? So the schedule for checking on them will be 2 hours. It cannot be every hour, because ideally when you don't produce enough urine to become continent. So they usually, when you have a patient on bed rest too, the tenant schedule, they always put it for every 2 hours to check the patient. Restraints, you want to assess the restraints. Sometimes facility will tell you every hour, but you can do those ones every 2 hours to check for blood supply to extremities. but facility policies sometimes count. And if they say every hour, it's every hour. But mostly the standard will be every 2 hours for checking dryness. So a client with epilepsy is taking phenytoin. Who know what phenytoin is?
Anti-seizure drug.
Anti-seizure medication, good. So the client is taking phenytoin. What long-term effects should the nurse advise the client can occur with prolonged administration of phenytoin? And I have it as a select all that apply. So if you were advising the patient who is getting phenytoin, what advice will you give them?
Number one. Yeah.
Number one, gingival hyperplasia. So if you don't know what phenytoin is, I advise you to go and look for what phenytoin is, and you read about the side effect and what it's supposed to do. Okay, and what again?
Number 3 is there.
Number 3 is dementia. That's
So number 3. Number 3.
Oh, hypertrophy of facial subcutaneous tissue. Yes, number 3 is correct. And what again?
Maybe number 5. I'm not sure, but maybe 5.
Anemia? No, it's number 2. Okay, so phenytoin is also called dilantin. Okay, dilantin. So dilantin is, it can cause, when the patient is taking dilantin, it can cause gingival hyperplasia, hypertrophy. That's hardening of the what's the name? Is there? Of
Gum?
the gums. Yes, hardening of the gums, hypertrophy of the gums, and hirsutism. So it make them look like their body look, I don't know, puffy or big, something like that. And the facial tissues too. Facial tissues too can look a little tense. It can look tense. So client, you have to advise the patient to always have good dental care. They need to have a good dental care, okay? And because of that, they can also develop osteoporosis as well. So you want to teach them to increase their vitamin D in their diet. Do we have any question? If not, we go on. This one had a lot of select all that apply. Okay, who want to read? Emilia, can you help us read this one?
A 60-year-old client has undergone a nerve-sparing prostatectomy and has been advised by his physician that he may not recover normal sexual functioning. The client is very concerned about this and asks the nurse for more information. Which of the following information should the nurse include? Apply all that, select all that apply.
Okay, let's go. So what will you do?
Sexual functioning.
What will you do? What answers will you pick? And how do you understand this question?
With the post-operative complications of prostatectomy, what is likely to happen after a prostate operation? So there might be retrograde ejaculation. There could be, it could take time to recover, up to a year. Other forms of sexual intimacy. No, I'm just reading it out loud.
So
D.
If a patient has prostatectomy, would their sexual function be affected or not?
Likely to be affected.
So you have the last 4 questions talking about sexual function. Which of them do you think?
Number D is the attempts at sexual intercourse are usually avoided for 1 month after surgery. Yeah. Number D is there.
D.
Attempt? I hope you're not looking at your answers. I don't see you looking though, but
I'm not.
No. What again? One more answer.
Anxiety can interfere with sexual functioning.
Why do you prefer anxiety over D or over F?
Other forms of intimate are more important than sexual.
If the person is conscious of the fact that he went through that thing, he'll be afraid that I may not really satisfy my obligation to this woman. So yes, that will make his libido to maybe his erection to come down immediately. So yeah, I think anxiety can affect it. Or
no, like I'm saying that why do you prefer that one over the F? What is wrong with the last one?
other forms of sexual intimacy are more important. No,
It's
it's not like kissing, cuddling. It's not. The main action is sexual intercourse. So
Okay.
and that one too. No, the scientific rationale is that those ones are not affected by the prostatectomy. Doesn't have any direct link.
Correct. That's what I wanted you to say. If it's other forms of sexual intimacy, then it doesn't actually affect the surgical procedure. If you know you will not be ejaculated, if you know you are not going to discharge, then there's no need. It will not affect it. So that answer option doesn't count. We throw it out. Okay.
Okay.
So those are actually the correct answer options. So the client may want to explore other forms of sexual intimacy. That is if it is important for them, but at this point, it doesn't actually affect the surgical procedure. So the recovery rate usually varies. Recovery rates usually varies, but for at least up to a year, you expect them to do much better. But for sexual intercourse, they can resume after 1 month if doing okay. And sometimes anxiety too can interfere into their sexual life. So you also want to take notice of that option. Anxiety can interfere. Okay. Who has a question on this? Before that, I'm just going to chip in some medication antidotes for you guys. Medication antidotes. So I have the magnesium sulfate. If you don't have a book, you can write this one down. Magnesium sulfate. So if a patient is taking magnesium sulfate, you know, we give magnesium sulfate when a patient has preeclampsia. When a patient has preeclampsia and has seizures, we give it. It's a smooth muscle relaxer. So it's a smooth muscle relaxer. The antidote is calcium gluconate. Calcium gluconate. That's the antidote for magnesium sulfate. We have acetaminophen, Tylenol. I'm talking about overdoses of these medications. If a patient overdoses these medications, then Tylenol, the antidote for Tylenol will be N-acetylcysteine. It is given oral. N-acetylcysteine, and it's oral. That's Tylenol overdose. Insulin. The antidote for insulin is glucagon. The antidote for Tylenol is glucagon.
Insulin.
Oh, insulin. I'm sorry. The antidote for insulin is glucagon. And the antidote for morphine is naloxone. Naloxone. Potassium, the antidote for potassium. These are a couple of them, so take note. The antidote for potassium is insulin. Antidote for potassium is insulin, sodium sulfonate. Insulin and sodium sulfonate given together.
What about chiasalate?
You say?
I said, what
Yeah,
about
that's the
chiasalate?
sodium polystyrene sulfonate.
Oh,
It has another name. They usually call it chiasalate. So bring it down. But that is also added with calcium in it.
Okay, so sorry, call the name again, the second name you called it.
Sodium polystyrene sulfonate. Okay. Now, let me chip in. I spoke about phenytoin, dilantin, right? I spoke about dilantin. Is that phenytoin?
It is.
Oh, okay. That's the one I spoke about in the question, right?
Yes.
Let me see if I get that question. No, I don't even see it. I don't even see the question anymore. Okay, so I spoke about dilantin. Let's talk about some anticonvulsant medications, okay? So phenobarbital, that medication will decrease blood pressure and respirations. It will decrease blood pressure and respirations, and you want to instruct the patient to take vitamin D supplements in case of need, okay? So vitamin D supplement may be needed if a patient is taking phenobarbital. It's an anticonvulsant. So phenytoin, those are anticonvulsant, anti-seizure medication. So the next one is phenytoin. I just finished talking about phenobarbital. Now is phenytoin. You do not give phenytoin. Huh?
They don't belong to the same class, right? Even though their names want to sound similar.
No, they are all anticonvulsants.
Like one is a barbiturate.
Yes, when it comes to classification, but they all have a similar function. They are all used as anticonvulsants. So for phenytoin, you don't give it with food, okay? Do not give with food and do not take with oral birth control. Phenytoin doesn't go with oral birth control because it wouldn't work. It will inhibit the function of the medication. So for something like this, if they ask you a patient is prescribed phenytoin, the patient tells you, you look into the list of the patient medication, which one will you question? You will question it if you see a patient is on any birth control pill. That's where you question. That's how the NCLEX will ask you questions like that. So they'll tell you the patient is diagnosed of so and so, having convulsions. The doctor has prescribed phenytoin. Which of the following will the nurse question? Or which of the following statement by the patient will the nurse follow up? So if you are giving this medication through IV, you can only give it with sodium chloride. You can't give it with D5. Okay, if you are giving phenytoin as an IV medication, you can only dilute it with normal saline, not D5. Now let's look at valproic acid, Depakote. Valproic acid, that's Depakote. This one is a hepatotoxic agent. It is toxic to the liver, hepatic. And you want to watch for abdominal cramps for patients who take valproic acid. And it can cause suicidal thoughts. The patients who take that can have suicidal thought. So if NCLEX asks you a question, a patient is prescribed valproic acid or Depakote for seizures, and the patient is here today, or they don't want to tell you the patient is taking that medication. They tell you a patient has come to, or a nurse is assessing a patient for suicidal ideations. Which of the following medications will you question if the patient takes it or not? So which of the following medications? You want to note that valproic acid, that's Depakote, is for seizures. Patient taking it, it can cause suicidal thoughts in the patient. So that's the medication you would question. This is how they frame the questions for you. Now let's talk about gabapentin. Gabapentin. So gabapentin can cause memory problems. For patients who get gabapentin, they can have memory problems. So you tell them not to take it with antacids because it will not work. It will inhibit its function. Memory problems, don't take with antacids, and it will also help with symptoms of restless leg syndrome. They like to mention it. They'll make it look like it's a big condition. They'll say restless leg syndrome. You tell the patient not to take it. But for a general consideration of anticonvulsants, they can become toxic to the body system, or cause dependency issues. People who take all anticonvulsants, this one is now all of them, they have a problem with dependency issues, that's addicted to those medications. All anticonvulsants can cause drowsiness, and anticonvulsants should not be taken with antacids. You just want to avoid. It's not only gabapentin, all anticonvulsant medications, you want to avoid antacids. And because the antacids will decrease the absorption of the medication. And then they can cause elevated blood sugar, blood glucose. They may also change your urine color to light rust color, but this is not a dangerous sign, okay? Anticonvulsants can change urine color. Patient taking phenytoin, when they pee, you see the urine, it look weird, but it's not a dangerous sign. It cannot stain clothes. Unlike in the case of rifampicin, those TB medications, when patients get them, they can get, it can stain their clothes. So you do not give any of these medications before anticonvulsive therapy. If the patient has to go for any anticonvulsive therapy, you don't give them any anticonvulsants. And then you also want them to wear ID bands, okay? And there was one that I wanted to just chip that in too. Let me see if I find that one. I wanted to chip in something quick. Okay, I wanted to chip in these herbal medications. The herbal medications. Herbal medications, and what you should tell a patient who is getting any of these herbal medications. Are we writing? Are we taking note?
Yes.
Okay, so if a patient is taking garlic is a herbal medication, we know that, right? And it's supposed to lower blood pressure or cholesterol. Garlic will lower blood pressure or cholesterol. So what you teach the client is that 1 clove is equal to 4 grams of garlic, and it will interact with warfarin and aspirin. Clove is C-L-O-V-E-S. 1 clove. We know, who know clove? I don't know how to describe it.
1 clove equals what?
It's equal to 4 grams of garlic, and garlic also will interact with warfarin and aspirin. That means if garlic is there to lower blood pressure and cholesterol, it can also cause, it can interfere with medications, blood thinners, aspirin, and warfarin. St. John's wort. St. John's wort.
Excuse me, what does it do to it? Does it make them to be more effective, or it stops their effectiveness? I mean,
if it interact, that means it's not going to work right.
Okay.
Yeah. Anything that will cause an interaction, that means it's not what you want it to work for. So blood thinners are there to thin the blood. Blood thinners are there to thin the blood. And garlic will interact with the thinning process.
Can you spell garlic?
Garlic?
Yeah.
No, garlic. The garlic we eat.
Garlic.
G-A-R-L-I-C.
Oh, garlic. Oh, okay.
Yeah, the garlic we eat.
Okay.
You know, it's one of the natural alternatives. That's the, yeah. It's one of the herbal treatments. Then I have St. John's wort. St. John's wort. This is for depression and anxiety. We use that to treat depression and anxiety. So your teaching to the patient is that it will react with selective serotonin reactive inhibitors, SSRI. So you tell them that it's going to react. Okay, so they shouldn't take it. And then it can also cause sun sensitivity on the skin. And it can decrease the effectiveness of digoxin. So if a patient takes digoxin, you want to advise them it can decrease the effectiveness of digoxin. The next one is ginseng. 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 And ginseng will increase physical stamina to give you more stamina. Okay, so reduce tinnitus or ringing in the ears. So if a patient has tinnitus or ringing in the ears, ginseng will also help reduce it. So if they tell you that the patient is one of those who participate in sports, which of the following do you suspect the client to be taking to always stay active? It's going to be this one. It will increase stamina for them to participate in contact sports and all those running stuff. Your client's teaching is that you tell them it can cause hypotension when mixed with caffeine. So ginseng, they shouldn't mix it with caffeine because it can cause hypotension. And it can increase the risk for bleeding. Now, ginkgo biloba. Ginkgo biloba, Ginkgo. And the other name is Biloba. Ginkgo biloba. I've been writing it a long time. Okay, so that one is to improve memory. This one will improve your memory, okay? So if you want to memorize well for the NCLEX, you look for ginkgo biloba. So you want to teach the client that it can thin the blood, so they should not take it with any blood thinner, like warfarin and aspirin, Coumadin and aspirin. And it can also interfere with seizure medication. So the one you question, If a patient says, I have been taking Depakote, I've been taking Depakote. So you want, if the patient is taking Depakote and they tell you, I've also been taking ginkgo biloba because I do have some memory loss issues. I have intermittent memory losses. So you want to stop them. You want to teach them that it will interfere with the Depakote. So the next one is echinacea. We're going to go for break after this one. Today I'm going to be snappy. I'm going to leave a little early. I really don't feel so good. We have echinacea.
Sorry, before you proceed, the last one, it interferes with the absorption of which medication?
Huh?
The ginkgo biloba.
Oh, it interferes with seizure medication. I use Depakote as an example, but it's all seizure medications. The anticonvulsants we spoke about. It interferes with them.
Okay. Thank you.
Then I have echinacea. Echinacea is to prevent cold and flu symptoms, and it has an immunity boosting function. It can boost your immunity. That's what echinacea is for. It's to boost immunity booster, and also prevent flu and cold. But the teaching you tell the patient is that it can cause liver toxicity in renal patients. Patients who have issues with the renal system can cause toxicity. And it is not also effective with patients who has a history of HIV. So HIV positive patients should not take this medication, okay? Because it will not work for them well. The next one I put on is ginger. The only ginger that we know. So ginger is used to relieve nausea and vomiting. Ginger is for nausea and vomiting. So if a patient has DVT, you tell them not to take it. If a patient has a history of DVT, they should not take it. I do hear people talking about taking ginger to reduce their blood pressure. I don't know how that works better, but ginger interacts with blood thinners. If a patient is taking any blood thinner, you want to advise them about ginger, to be careful. So ginger is to relieve nausea and vomiting. And you teach the patient not to take it if they have a history of DVT. This is kava. The next one is kava. This one will treat insomnia. Those who are not able to sleep, insomnia, and muscle pain. So if a patient is taking Parkinson's disease medications, it will decrease the effectiveness of the medication. So kava is not really good with Parkinson's disease medications. And it can also increase suicidal ideation risk in clients with depression. So if a patient has depression and they're taking kava, they have a high tendency of being suicidal. Then let's talk about black cohosh. That is for menopausal symptoms. Patients who have menopause. Black cohosh is for menopausal symptoms. Okay, so for patients who get it, you want to teach them that it can be used to treat hot flashes, okay? For those of us who are yet to get into menopause, I think I need to start looking for that. So that the hot flashes I don't go crazy with that. So you teach them is used to treat hot flashes, and it's contraindicated in pregnancy. It will cause premature labor or preterm labor. So if a patient is pregnant, they cannot take it. It's contraindicated. The last one is saw palmetto. Saw palmetto is used for prostate problems. That's for men. So you want to teach them to reduce that. It will reduce absorption of iron. Just like the way you cannot take milk with iron, take notice, because milk will inhibit its absorption. You can take iron with antacids, iron with anything with vitamin C. But iron with saw palmetto for prostate problems, it will reduce the effectiveness of the medication. So if a patient is taking this medication, this saw palmetto for prostate treatment, there's a risk for false positive prostate specific antigen. They can get a false result for that. Okay. And it can also make the patient urinate a lot. It can produce a diuretic effect, make the patient go to the bathroom more frequently. But in general, what you tell a patient who take any of these medications, you always want to educate a patient who take any herbal medications not to mix it with the doctor prescribed or medically prescribed medications. You don't advise them. So you can put one down at a time and then you stop taking it for a while. So for a patient who takes ginger at home or a patient who takes garlic at home, and they are going to go for surgical procedure, you want to tell them to stop taking those medications at least a week before they go in for surgical procedures. Remember, I just said they can interact with blood thinners. So you don't want them to take that. So general advice you would tell, or general teaching, general education to a patient taking herbal medication is that all herbal medications that start with the letter G can cause blood thinning, like the ginseng, the ginger, the garlic, the ginkgo. You group them like that, they can all cause thinning of the blood. So you never mix them with Coumadin, aspirin, or heparin, enoxaparin. You don't want to mix them, or Levonox. You don't mix them. Those are blood thinners. And also, pregnant people, all herbal medications are contraindicated. I know they said ginger is for nausea, vomiting. We do eat ginger, but you cannot take it as a supplement, okay? Don't wake up and you make ginger drink because there's coronavirus. So it's all contraindicated in pregnant women. So you have to stop it 2 weeks, not 1 week, 2 weeks before surgery. All of them. You stop it 2 weeks before any surgical procedure because it may interact with anesthesia. And on this note, I'm going to take a break, okay? Today, I don't want us to close too late. I don't feel so good. When we come back, I'm going to talk about insulins and oral anti-diabetic medications, and then we continue back our questions, okay? So we'll come back 45 and continue. And we are going to close early today. So I'll see you 45. Okay?
All right.
Why?
On this. rapid acting insulin. And this one is used in insulin pumps. Sometimes the generic name will be insulin aspart, ASPART, insulin aspart, or insulin lespro, LISPRO, insulin aspart or insulin lespro. That's the generic name. And it is usually given with meals, or it can be given with meals, and you do not mix it with other insulin. Okay, so the rapid acting insulin is used in wearable insulin pumps. You don't mix it with any other insulin. So take notice of the names, insulin aspart and insulin lespro. You don't mix it with other insulin. It's rapid acting. It is given with food. The onset is 15 minutes or less. It's from 0 to 15 minutes. So 15 minutes or less. That's the onset, and it peaks in 1 hour. And it stays, the duration is supposed to be 3 hours for insulin aspart and insulin lespro. These are rapid acting insulin. Short acting insulin. The short acting insulin is the clear one. Remember last week we were mixing it? So this one will be the regular insulin. And it is the only insulin that can be given as an IV insulin. It's only regular insulin we can give it as IV push. Okay? And its onset is 1 hour. It peaks in 2 hours. And duration is 4 hours. The onset.
But can you, the duration for the rapid acting is what?
Duration for rapid action is 3 hours. Okay. And short acting is 4 hours. That's the clear insulin. And the clear regular insulin is the only one that can be given as an IV push. So that one peaks in 2 hours and its onset is 1 hour. So when you give it within that 1 hour, it starts working. Mm-hmm. Then we have the intermediate insulin. That's the cloudy one. For those who didn't understand what we were mixing last week, we're mixing the clear one and the cloudy one. So anytime they ask you about mixing insulin, it's going to be the clear and the cloudy one. The clear one is regular. So the moment you mix it with the intermediate acting one, you cannot give it as IV push. Okay? So the intermediate is the cloudy, that's the NPH. The name is NPH. These are their generic name. That's what NCLEX will always want to hit on for you. NPH. And this one, the onset is 4 hours. It starts working in 4 hours. That's what I mean by onset. And it will peak in 8 hours. So it will be in your body for up to 8 hours. And then the duration is 12 hours. So imagine if a patient's blood sugar is high now, you want to reduce it fast. That's why you use the regular one. And then you mix it with this one so that this one will stay longer. I explained that last time. Now let's look at the long-acting insulin. Mind you, the long-acting cannot be mixed with any other insulin. Long-acting insulin cannot be mixed with any other insulin. And that's the insulin detemil, DETERMIR, and insulin glargine. Insulin glargine.
Glargine.
Yeah, glargine. Insulin glargine. These are long-acting insulins, the two of them. Insulin detemir and insulin glargine. They are long-acting. They never mix with anybody. So their onset is slow absorption, and they don't have a peak. They don't have a peak time. And it's 24 hours, same time each day. It's like a standing order. So every 24 hours, you take it at the same time every day. The last one is a premix. The premix insulin, 70/30. the one that comes already mixed up, 70/30. We have the humulin. So the 70/30 contains 70% of NPH. Remember I spoke about NPH as an intermediate cloudy one, and it contains 30% of regular insulin. That's the clear one. That's the one that they have one that is already pre-mixed. So if you are mixing it, this is what you are getting. So we have the pre-mixed one that is already mixed, and it's called humulin, 70/30. Usually they have pen for it. It comes as a pen. Any of this can come as a pen anyway. So the humulin is 70% of NPH and 30% of regular insulin. The onset is 30 minutes. It peaks in 2 hours. And then the duration is 16 hours. Remember, they have a long acting one. They have a intermediate acting one in it. So it peaks in 2 hours and duration stays in your body for up to 6 hours. Now let's talk about some oral diabetic medication or oral anti-diabetic medications. But before I go to the oral one, so for a patient that is taking, what's the name? Insulin, the medication on the pancreas, you want to teach them. If you want to teach a patient that gets insulin, you want to teach them that the medication acts on the pancreas, okay? And stimulate the pancreas to produce more insulin. It stimulates the pancreas to produce more insulin. Then the medications are for 2 types, or are for type 2 diabetes only, okay? These are the oral medications. Oral medications are only for type 2 diabetics. What they do is they stimulate the type 2 diabetes. The patient's pancreas produces insulin, but it doesn't just produce enough to meet the body requirement. It doesn't produce enough. So you teach them that it will stimulate the pancreas to produce more insulin. That's what it's supposed to be for. And it's for only type 2 diabetes. So any medication that is mentioned that is a tablet and it's a PO insulin medication, that means the patient is a type 2 diabetic. Type 1 is insulin dependent. They don't even have the pancreas to create enough for them. So they just depend on the insulin to work, or the pancreas doesn't work, doesn't do its job. So the medications must be taken with meals. Don't give insulin and the patient is hungry or starving. You are going to let them go into hypoglycemia. So we have the first medication is glucophage. Glucophage, GLUCOPHAGE, glucophage. You do not give this medication before or 48 hours after an intravenous pyelogram. So both of this medication and dye, you don't combine this medication with a dye, okay? Because it can cause kidney damage. That's one thing you want to note. I'm not going to go into details with that, but I'm just letting you know, like, things you should be concerned about if a patient is getting oral anti-diabetic medication for type 2 diabetes. So you tell them that they are not supposed to take this medication 48 hours before any intravenous pyelography or intravenous pyelogram, because intravenous pyelogram, when they go to view the renal pelvis, they have to use a dye. So this medication is not supposed to mix with a dye because it can cause kidney damage. The next medication is glipizide, glipizide glyburide, glipizide and glyburide, basically the same. You tell them to take it early in the morning, okay? And it may drop the blood glucose levels quickly. When they take it in the morning, it may drop the blood glucose level. So you want to teach the patient to have a snack available. So for a patient that takes this medication, you want to tell them to always have a snack with them, because the medication can also cause jaundice. So you want to teach the patients about this medication like that. The medication can cause jaundice, and you teach them to have a snack with them at all times. Let's talk about rosiglitazone, R-O-S-I. Maybe let me spell this one. Are we taking notice or we are just listening? Hello?
I'm taking notes of others.
So they should take it early in the morning, and then they should have snacks by them. Okay.
Ready, yeah. In case you start feeling shaky, you take a snack. Or even all day when you are going. If you're on that medication, you don't want to have hypo. This is the next medication I'm going to talk about. I'm not pronouncing the name well like that. Rosiglitazone malate. It can also cause jaundice. So remember I said the glipizide and glyburide can also cause jaundice. This one too can cause jaundice. And this one may decrease the effectiveness of oral contraceptives. So if a patient is type 2 diabetic and you want to educate them about their oral contraceptives and you know they are taking this medication, you have to caution them against that. They'll be taking the oral contraceptives and they get pregnant. Okay? So if you don't educate them well and they get pregnant and they found out that you gave me this medication, you know I was taking oral contraceptive and I went and I got pregnant. I never want to get pregnant. That's why I first of all asked for this. This have caused a lot of lawsuits where a patient, you will tell the patient this, that, and you miss information. Patient don't want to get pregnant. They come back pregnant, they can sue you for that. So that's why you, the nurse, need to have your nursing knowledge well organized. You need to know your stuff. If you don't know such information before you tell the patient, don't tell them what does not exist and try not to miss it. The next one is exenatide. That's the last one. Let me spell it. That's the last one for the oral one. I didn't add what's the common one that they take. Metformin. I didn't forget about it. Go look for it. I know anywhere they mention that one, you will know what it is. So there's no need. Exenatide. Okay. So this one is a subcutaneous injectable medication. It's not necessarily a pill, but it's classified with them. It is not recommended for clients that take insulin. It's for type 2. So it's a subcutaneous injectable medication as well as a pill. You can have both of that. And it may cause GI distress. So for client teaching, you want to teach the client that oral antidiabetic are contraindicated. They are contraindicated with warfarin. When a patient is taking Coumadin or warfarin, oral antidiabetic medications are contraindicated for that. And also oral contraceptives and corticosteroids. You know, corticosteroids will further increase the patient's blood sugar. So you want to teach them to avoid that. You don't want them to take it because they'll get a rebound problem. And here you go, you'll be in trouble. You see the next running. So that's what I want to tell you. Can we go back to our questions? Or I can just chip these ones inside. Can I chip these ones inside? This one is about cardiac stuff. I know when it comes to this cardiac stuff, it does cause a lot of thing. So, but I want to just talk about anti-arrhythmic medications, like when the heart rate stuff and all those, so AFib and what to be treated for. So I really wish you could take these things down. So for a patient that gets atropine, the actions you will see is used for. Actions are what the medications is used for. So atropine is used for bradycardia, okay? When the heart rate is low and you want to kickstart the heart, you will give the patient atropine. I'm typing it. My thing is so big. So if you want to kickstart the heart to beat faster, atropine is used for bradycardia. For brady, and it speeds the heart rate. It makes the heart rate go up higher. So for a patient that the heart rate is very low, you will give them atropine. But it can also be used for asystole. After you have given epinephrine, it can be used for asystole. So for an EKG rhythm that is asystole, you can give atropine. That means there's no pulse. You give the atropine after you have given the epinephrine for that. Let's talk about amiodarone. Amiodarone is DA. This one is used for AFib. So you see the rhythm and its atrial fibrillation. You can give amiodarone. VFib, ventricular fibrillation. VTAC. These are the three things you can use amiodarone for: AFib, VFib, and VTAC. You give amiodarone. Then the function or the action is supposed to slow the heart rate. Amiodarone is supposed to slow down the heart rate. So if the heart rate keeps going up higher, it will cause it to slow down. Remember, atropine will cause it to go up higher. Then let's talk about cardizem, deltiazem. Deltiazem. It is used for AFib, atrial fibrillation. Remember the atrial activities of the cardiac rhythm? The atrial activities of the cardiac rhythms. That's the P waves and the T waves. So cardizem or deltiazem is used for atrial fibrillation, and its action is to slow the heart rate as well. It will slow down the heart rate in atrial fibrillation. The next one is Mr. digoxin. I used to get scared of digoxin. I don't know why, but when I first started nursing, anytime I hear a patient is taking digoxin, I get so scared. I don't know why, but I think it was just a pre-made up of my mind based on what I had studied about digoxin, but I really never saw it with my eye until I became a veteran nurse. Then I saw it and I use it. So I realized that it's not anything to be scared of. I think it was just childish thinking though. That was like 12 years ago. It was childish thinking, I think.
But it's a big name in cardiac treatment.
Yeah, I think that was why. Maybe the way my professor handled it in school, it just kind of placed some kind of fear in me about digoxin. So when I hear digoxin, I feel like it's something big deal. It's just the mind that did that. So it's used for AFib as well. So digoxin and cardizem or deltiazem are used for AFib. So when you have a question presented to you with these two medications, you want to really be careful because they both do the same thing. So if the question has both of them in the answer choices, you want to make sure that they are not asking for a negative statement because those two will be correct. They are both used for AFib and they are both used to slow down the heart rate.
Okay,
Then,
amiodarone.
You say?
I said including amiodarone.
Yeah, amiodarone too. Yes, amiodarone is used for AFib, VFib, VTAC. So those three medications. So amiodarone, diltiazem, and digoxin. You want to be careful. Those three medications they use to slow down the heart rate. Epi, almighty epinephrine. Epinephrine is used for absent heart rate. That's asystole, and it's used to speedy up the heart rate. It doesn't slow, it speedy up. Remember atropine? Atropine was supposed to speedy up the heart rate, and atropine will be given in the case of asystole. And so epinephrine will be given in the case of asystole. Then lidocaine. Lidocaine is the last one. Lidocaine is used for VTAC, AFib, and lidocaine will slow the heart rate. Remember, lidocaine too is a form of anesthetic. Can be used as a local anesthetic agent. And another thing about atropine can be used as an eye drop. We have eye drops that are atropine. It will dilate the pupils, okay? Atropine can cause dilation of the pupil, so we call it a mediatric medication. So when you see mediatric medication, atropine can be used as an eye drop to cause dilation of the pupils. So these drugs will affect the rhythm of the heart. All these medications will affect the cardiac rhythm on the cardiac monitor. So some of them will cause slowing of the heart, others will cause the heart to be jumping up higher. Okay. Are we done? Hello? Hello?
Hello.
Okay. Any question? Does anybody have a question?
Yes, please.
Yes, what's the question?
When you use atropine as an eye drop, does it also have the effect of dropping the heart rate? I mean, of making the heart to beat faster if you use it as an eye drop?
That's when it causes systemic absorption. That's when the conjunctiva, remember when you are given eye drops, it can cause systemic effect. Do you remember when you are given eye drop, they tell you to put pressure here so that it doesn't get to the cornea because it can cause systemic effect. That is only when that happens. Besides that, it's not, it only affects the eye side. The eye drop form of it will only cause dilation of the pupil, and there are different concentrations. It's not going to be the same concentration as giving it as an IV medication. So the concentration of the atropine that will be used as an eye drop would definitely be different from the concentration of the one that will be given in the case of
Judith, are you scared?
Huh?
I think she's scared. She just an eye drop and I think
Nobody's getting eye drop.
Yeah, she saw me dropping mine.
Huh?
I used mine a while ago. I didn't use it since morning. My eye drop, but it's not atropine though.
Okay, I have a question. If a patient has dentures and you remove the dentures, should you put it in cold water or in warm water?
Cold.
Hmm?
Cold. One.
You use tepid water, okay? Not cold. Put it in warm water. Okay. Do we have any question? If not, there's a question I want us to discuss and then we hang up. I want us to talk about one of this question that was question number 21. I want somebody to give me a detailed analysis of how you understand that question. And we answer that question and then we are gone. I don't even find my questions.
Can you bring it back? Okay.
Is there?
No, I know I didn't start the class with you, Nancy. Can you please bring it back?
Bring which one?
The 21 you were talking about. You bring it on screen.
No, I'm going to put it.
Okay.
No, everybody was late today.
Oh yeah, I thought I was.
No, the class is late today. I just accepted them in when you came. It was less than 3 minutes. So you were not actually late.
Thank you.
Yeah, today everybody was late. And it's Emilia who came a little earlier, but I was also doing something. I didn't want to stop. So I decided to just finish up. So I didn't accept her in on time.
Okay.
Oh boy. I was busy using it, so I didn't want to stop or pause the one that I was doing. I can't even find what I'm looking for. I have so many things on my screen open, and sometimes it's very difficult picking up one and leaving one. My computer, the desktop we have in this house, it doesn't go off.
It's always active.
It's like the work desktop is always working. Everybody put it in. We don't close our icons. Everybody is just working. It's a 24 hours desktop.
I won't be important.
Then it's
Yeah.
Do
wrong.
not overwork the poor thing.
I know it's been going on for like maybe 4 years now. Once in a while, when you turn it off, you will wait for like more than 20 minutes to have it come back on because the mind too has been programmed. The laptop, the desktop has programmed its mind, so it doesn't go off. Everybody is disciplined. Okay, so I'm going to read this question. I want somebody to just give me a vivid analysis of this question. We will answer it and we go away. I think this is easy. A client who was prescribed an increasing dose. Let me increase the font size so we can see it better. Who was prescribed with an increasing dose of baclofen. Baclofen is the medication to relieve muscle spasms. Should have taken 80 milligrams daily in 4 divided doses. The client should have taken 80 milligrams daily in 4 divided doses. So total for a day, how much was the patient supposed to get?
80.
80
milligrams.
80 milligrams, 4 times a day.
No, all together. All together, everything. So it should be divided like 20 mil for each dose. I don't know if
in 4 divided doses. So you divide the 80 by 4. Is that what you mean? Yes. So that means the client is supposed to get 80 milligrams for the whole day. And the 80 milligrams should be given it should be given 4 times a day.
6 hours, maybe.
4 times a day. So the 4 times a day will be 20 milligram, 20 milligram, 20 milligram, 20 milligram. Who doesn't understand this analysis? That was another way they could have used to ask you in the answer options, okay? Now, the client should get 80 milligrams daily in 4 divided doses. I'm trying to draw your attention to understanding the question before you look for answers. So if you don't understand the question, you cannot look for the correct answer. Okay, so, but misunderstood and took 80 milligrams 4 times a day. So in total, how much did this client take? If the client misunderstood the instruction,
It took 320 milligrams.
so that means for 4 times the client took 80 milligrams every day, right?
Mm-hmm.
Correct. I like that. Resulting in an overdose. So the moment they mention overdose, I'm going to think, what's the antidote for baclofen? That's the next thing I'm drawing your attention. When you are reading the NCLEX questions, I want you to cut them in pieces and understand them. Resulting in an overdose and pronounced central nervous system depression. So the next thing now, they have brought baclofen causing central nervous system depression because the patient took too much of it. That's an overdose. So if it's insulin, I'm already thinking of antidotes. If it's opioid, I'm thinking of antidote. If it's potassium, I'm thinking of antidote. This is baclofen. It's an NSAID. I don't even know. So which of the following treatments does the nurse anticipate? What do you think you will do for these patients?
I would say administer atropine.
Why will you administer atropine? Remember they said central nervous system depression. So this is what takes you to your understanding of what symptoms the patient is likely going to present if the central nervous system is down. That means patient can have memory problems, patient can have thinking problems, walking problems. Patient can have a lot of problems at this point. The brain is damaged. Take it like that. The central nervous system is depressed. It's not working. So you will give atropine.
Okay, if that's the case, then I would
Is
say
atropine the antidote for baclofen?
No.
I'll give naloxone.
Is naloxone the antidote for baclofen? Naloxone is an antidote for opioid. Is baclofen an opioid?
No, it's an NSAID. Baclofen, it's an NSAID, right? For muscle spasm.
It's a non-opioid analgesic. You can call it that. Non-opioid. If she says she will give naloxone, naloxone is an NSAID. No, baclofen is an NSAID, anti-inflammatory. It's a pain medication, but it's for anti-inflammatory. It's not in the class. So you cannot give naloxone.
So I would say see them patients. Give
You
supportive care. See.
You say?
Supportive care.
Why will it think supportive care?
Okay, so I can't give atropine because it already told me that there's the CNS depression, right? And the antidote for the baclofen is the atropine.
The antidote for what?
The baclofen is atropine. Is what do you call it? Atropine? No?
I didn't hear you. I didn't hear what you said.
The antidote for the baclofen is atropine.
I didn't get you.
What about if we give last option?
No,
I know.
Huh?
No, I'm preferring my own answer now. I said, what if we give the number 4 option?
Do you know what number 4 is?
I know it's an antidote too, but I'm thinking, I don't remember the class of medicine. It's an antidote.
Benzodiazepine.
Because why I say that is because now the person is overdosed, most likely going to have respiratory depression and the rest of the thing. That is it. That is CNS depression. So I think, or I don't know if I'm wrong, the flumazenil.
It's a benzodiazepine antidote.
Antidote, okay.
Yeah, if a patient overdose Vesid, Xanax, that flumazenil is the antidote for those medications, benzodiazepines. So I think Simone is correct for supportive care, because that's why I took you through to rule out reasons why none of these things fit.
Mm-hmm.
So all these things does not fit anything to reverse the medication. It tells you that it's either that medication doesn't have an antidote, or the question don't even want you to manage it with an antidote. But you cannot conclude that atropine will help with respiratory rate or heart rate, because they didn't mention any heart problem. They said central nervous system. And all the other antidotes, if you know what they are, or all of them are, you know, atropine will not work. You know, naloxone is for opioids, and this one is not an opioid. So if this one is not an opioid and the patient have overdosed it, this is just a pain medication for NSAIDs. And this one is benzodiazepines. It has nothing to do with baclofen. So you look at all these answer options, and the only one that will make sense is to give a supportive care. Anything with central nervous system depression, the patient is going to need a lot of support. Do we understand? So in order not to change the question, you need to have understood that central nervous system is already depressed. There is no medication to reverse that effect. The central nervous system is affected. The patient brain is like, the function is now 50-50. So it's supportive care you can give to this patient. You cannot reverse it. You cannot pull back the medication. Patient has been taking it 4 times a day for 2 weeks, for 3 weeks now. Central nervous system function is gone. It's all depressed. So all the other medications they put in there is just to confuse you, to make you think that the patient will need an antidote. But which of these antidotes will fit this criteria? Nothing. So none of them work for NSAIDs. So actually, to let you know, NSAIDs doesn't actually have antidotes, okay? Yeah, NSAIDs doesn't have antidotes, but you know Tylenol has. I just gave you that. Do we understand?
Yes.
Okay. Patience, do you understand how we analyze the question?
No, stop it. No.
Where were you? Okay, where didn't you understand? I don't think you were by your computer. I don't think you listened to that. Where didn't you understand? Yes. Where do you have a question with this analysis we did?
This analysis, I don't understand why you give supportive care only.
It's not a select all that apply. So what will you do for these patients? And what is the management for central nervous system depression? Do we have supportive care in that? And my next question is, do you know what naloxone is? Huh? Do you know what naloxone, atropine, and flumazenil is supposed to be used for? You know what they are?
Yes.
What are they? Tell me each of them.
What I know is they are used to treat drug overdose.
And do they treat all drug overdose or they have specifics? What is flumazenil used to treat? I mentioned that, so that means you didn't listen. It's a benzodiazepine. Flumazenil is a medication to reverse overdose of benzodiazepine. So it's not to reverse NSAIDs. Baclofen is non-steroidal. Now, this is another thing I am telling you. That's why I'm pushing you to study the content so well. Because if you read this question, this is a question that is bringing a medical problem, that is central nervous system depression. It is bringing baclofen. So this is a pharmacology medication plus talking about nursing care. So two things mentioned in this question to give you a clue is the fact that the patient is taking baclofen. That means the patient has pain somewhere. And they have specifically told you is to relieve muscle spasms. So if it's to relieve muscle spasms, in the first place, if you read and you don't understand what baclofen is, that's where you are going to go and start choosing any of the antidotes. The next thing is, if you don't understand that naloxone, atropine, and flumazenil are antidotes for other medications besides baclofen, then you are going to pick one of them. But if you understand that naloxone doesn't have to do with an NSAID, it's an opioid antidote, which I know everybody can easily figure it out. Atropine is a medication used to slow down the heart rate. So if it's used to slow down the heart rate, now why would I even give it with central nervous system depression? Flumazenil, I know what it is, and I know it's a benzodiazepine reversal medication, antidote for benzodiazepines. So why will I give it if the patient have already developed a complication from the antidote? And that complication is central nervous system depression. This involves the central nervous system. So this takes me back to thinking of my nerves and my neuron functions. So I start thinking of central nervous system depression. The patient will have so many problems to manage at this point. They didn't tell you how long the patient have taken it, but you can see the massive damage that will be caused on the patient based on the dosage. 80 times 4 days. That's why I asked of the total number, and I think somebody mentioned 300 and something a day instead of just 80. These medications are ordered based on patient body size and weight. So if the patient is overdosing that means the whole central nervous system is collapsed by too much dosage of the medication. You can't do anything than to support. You have to be supportive. If you remember in all the videos, I always talk about you, the nurse, has to be supportive in your care. Supportive care is a form of nursing care you do to a patient. So looking at all the answer options, if you didn't have an idea which one to choose, and you know that all these things, they didn't mention heart rate, they mentioned a major problem, that is central nervous system. It's going to be a general management the patient will need, and that is supportive care. You can't really fake any medication to reverse the adverse effect of that medication at this point. The damage was done. Okay?
Okay.
Any other question? Because we are going to end here today.
But in a clinical setting, I have a question. In a clinical question that is not a setting, that is not a question, for example, in the emergency room where we work, if such a person comes, in addition to the supportive care, or is it included? But I know that something like a normal saline might be given. That's the part of the supportive care you mean?
Yes. So that's another thing that I try to take out of your mind, because this particular question, this is not the only kind of care you will give. Being supportive, I am just supporting you to feel good, to feel comfortable. You understand? I make you know that I understand you have a problem. I'm there for you. I'm there to do this and that and that. I am putting an IV, I am doing all these things. That's okay. But this is not the clinical setting. This is a question that they want you to go specific with some specific kind of care you will do. You understand? So they took away all nursing care. They didn't put you will check the vital signs. They didn't put you ask the patient a question. What they want is what you will think should be done for this patient. They want you to know that nothing can be done apart from doing nursing care. IV lines and all those IV fluids, you would give it. But this is a question that is going specific. That is NCLEX. So you cannot go assuming that you would give IV fluid, you will give this one, you will give another thing, you give a medication for the patient to sleep. Don't be surprised to come and see them give this patient another medication to make the patients relax. You understand? They can give, that's the clinical setting. But in the world of NCLEX, they just presented you with only 4 things that they want you to tackle. Only these 4 things, they want you to sort out what you think is the best among all of them. I don't know if you understand the analysis I'm making. So your aim for this question is not complete nursing care of what will be done if it was in the facility, because you are not just going to see the patient like that and you start being, I'm supporting you. No, you are going to provide a whole lot of nursing care. But for you to give antidote, there is no antidote. So nursing care is the only thing you can do for the patients at this point. So that's the reason why you cannot think for NCLEX. Any question they present to you is a complete question. Don't bring information outside and add to it. You could have done vital signs for this patient. That's true. You could have assessed neuro check for this patient because central nervous system is involved. You understand? But they didn't jump into any of that. They just went straight to know what you will do. And antidote doesn't count. So the only thing that counts is being supportive. Okay?
Okay, thank you.
Yeah, so try for what you see in the facility, don't bring them into the question. Every question they present to you is a complete question. You don't need more information inside that question. All you need has been provided. So just stay focused, read all that question, understand that question. All the critical words or the most important words are mentioned inside that word, and it is enough for you to have a clear understanding of what they want. I think I sent out a video last week. Did you see that video, Clementina? The one I was talking about answering the questions, how the question, I spoke about questions, strategies, and answering strategies.
Oh, look, I've not seen it.
I remember you asked me about that and I did it. That same day I did a video for that. Go over that video. I did a question under how to read the question and make meaning from the question before you jump to answers, how to go over the answer choices, make meaning over it. And then if you just don't have an idea how to tackle that, I did a video on it. I think I did send that video out. I will check, but check too in the videos that I sent last week. I think there was one that I spoke about some strategies, and I just based on the questions alone, understanding the question and how to understand the answer options and how to sort them out and pick the correct ones. I know it's a lot of videos, but try to go over that. So don't read meaning into that question. Don't bring a lot of material into questions because that will not help. It will make you miss out the correct ones. Okay? Oh, Jesus. So on this note, can I hang up?
You can.
Am I free to go?
Yeah.
Thank you.
Thank you.
All right. So everybody have a good night. I'll see you on Monday.
Yeah, by God's grace.
All right. Bye-bye.
Good night, everybody.
Good night. Bye. Bye.
Yeah.